they all end with ultrasound. They all suggest ultrasound testing. And they make, by the way, this is from 2 weeks ago, this is the current update from the American College of OBGYN. And basically it says that even a negative test, even a reassuring ultrasound test, should not be taken as reassuring. So, not exactly the best answer.
So I'll try to agree with everything that Dr. Marconi said, try to be a little more optimistic. There are certainly supported evidence, and it's not definitive, to suggest that if you test negative now, and you're pregnant, and your IgM is also negative, and your sonograms are negative, then you really don't have anything to be concerned about. Overwhelming likelihood. The woman did test positive, so that none of these tests are then of any value if she's pregnant, and then you need to really just follow the baby with serial sonograms. I think the question that comes up much more frequently for United States obstetricians is, the woman is not infected. She wasn't in an endemic area. What do you do with the partner? Those are the questions I've been getting. I think it's relatively easy to say, we're going to do serial sonograms on somebody who's infected, and let's hope for the best. That's all we can do. But that's easy from a what do we do point of view. That's the only thing we can do. I think the much more common question is, if the husband traveled on business, pleasure, whatever the situation may be, and now they're pregnant, what do they do? And that's where we discuss what the CDC recommendations are, where the science behind those recommendations, and where the public health safety behind those recommendations come from. And that's a decision that I think needs to be personalized for each patient with their doctor, if they understand what the facts are, to make the best decision for that patient and that family what they wish to do.
My question is, for those women, couples that choose to have sexual intercourse, contraceptive-wise, you know, I've heard through the media, and I have to use them as an example because obviously the stories are out there, to do, you know, condoms, you know. So what are your choices, you know, for those women that say, you know what, I have sex, I want to have intercourse, and for the men that also want to communicate that opinion?
So again, I think it's important to understand what we know scientifically, what we don't know, and then every person has to make their own decisions. The only cases transmitted so far, only documented evidence of sexual transmission, have been from men who were clinically sick. Not from an endemic area, not that they had a positive blood test, but were clinically sick, either before, during, or after the time that they had the intercourse. Only those men were transmitting to their partner. The majority of the cases of transmission were in men having relations with another man. There only are a very small amount of cases of a man transmitting to a woman that have been documented. But clearly, it's possible. And again, this is what I mentioned before about relative risk. We have this, about sexually transmitted diseases. This is not a new phenomenon. There are different behaviors that are more risky. We try to get an estimate or a guesstimate what the individual risks are in every situation. Then the people involved, hopefully two consenting adults involved, can make their own assessment of the risk. The risk is, as I said, from a symptomatic man to another man would be the highest risk. From a symptomatic man to a woman would be a slightly lower risk. All the other risks are unknown what those risks are. They include an asymptomatic man who tested positive. An asymptomatic man was in an endemic area, never had a test. A symptomatic or asymptomatic woman. So those are the unknowns at this point in time. We hope we have data in the next couple of months as we learn more and more about this disease.
But I think what you're asking was, what, you know, is there one contraceptive better than another? And the answer to that is no, they're all, because if you, whether someone's infected, actively infected or not, and they're going to transmit it or not, or it's heterosexual, you know, the only pertinent episode, the only pertinent situation here is heterosexual transmission, because the only thing that matters is if the woman were to get pregnant. So no matter what type of contraceptive you use, the effectiveness of that contraception prevents the worst part of the Zika virus. If a woman was to catch Zika, a woman taking the birth control pill or with an intrauterine device was to catch Zika from her male infected partner, but did not get pregnant, okay, then she'd get joint pain for 2 weeks and then she'd be better and she wouldn't have a baby with microcephaly. So I think that's a good.
The woman, or I guess the guy too, once you acquire Zika, does it confer any kind of immunity to you in terms of getting rebitten or reinfected?
So that's a very good question. I don't think we have the complete answer to that. But the answer is probably yes. There hasn't been a single case yet of somebody who has Zika twice. Only been around a short enough period of time, say that 10 years from now that couldn't happen. But I think it's reasonable as with many of these viruses, which we do have a lot of experience with, when you get natural immunity, it often is lifelong immunity. But it's not 100%. So I can't guarantee that, but I think the working assumption would be at this point in time that there's a likelihood that that would be true. People don't get some of these viruses more than once.
Well, by the same token, if I may, I should just ask, when you're saying, if a woman contracts Zika before she gets pregnant, you're saying to wait 8 weeks. Is that it's a virus that's being contracted, a virus is always in your system? Could there be some theoretical risk if she got pregnant even 2 years down the road, the fact that it's still on her?
So that's a very important question, and I'll throw back at you what you said, the virus is always in your system. That's not necessarily true. With some viruses, for example, the entire class of herpes viruses, which include chickenpox, which include a whole bunch of other viruses, and herpes, that's true. We never can clear it from the body. It's always dormant. But with other viruses, they are cleared from the body. I think the experience is that all of these types of flaviviruses, which include dengue, chikungunya, and other flaviviruses, are cleared from the body. So I think the likelihood of this happening would be very, very low.
Thank you.
So I have a pregnant daughter and a pregnant daughter-in-law who canceled their trip to Aruba and are panicking. And I think part of the panic is that we haven't had mosquito season yet. So whatever you say could change very radically, very quickly as the weather heats up. Now my daughter-in-law is in Massachusetts and she's supposed to come to Lido Beach for the summer. And she tells me if there's one mosquito, she is staying up in the Berkshires. My daughter is going to Israel. What is the international scene? And is she safer in the Berkshire Mountains than in Lido Beach? And we're all panicking. Thank you.
So that's a very important question. That's the questions that I get several times a day about people traveling. So in the current state, I can only answer for today. I can't tell you what's going to be in the summer. We've not had dengue in New York. We've not had a lot of chikungunya in New York. We've had some. We've had some West Nile in New York. Every virus is different. Every year is different. And therefore, right now, I would tell you absolutely she should not spend as much time with you as you can tolerate. That would be my advice. In Israel, there are no reported endemic cases as well. Before a person travels to any place, they should look on the CDC website. You can just Google CDC and the name of the place you want to travel to, and they'll tell you whether there are cases there. They can also give you good travel advice. It's a very smart way for people when they go into areas, what vaccines do they need to take, what regular treatments or preventative measures they should be taking. So that's a good thing to do without Zika. But certainly, a pregnant woman should be concerned about where she's traveling in general, not only because of Zika. But I would reassure you at this point in time that she shouldn't have any fears about coming to Long Island, at least not at this point in time. And my guess, if you push me against the wall, would be that she won't have those problems anymore.
I don't know if you
you've seen the Channel 2 explanation of how mosquitoes breed or not, but the female mosquito is the one that bites you, not the male mosquito. And also, that they're doing DNA on the mosquitoes now to try to stop them from breeding. And they have to test them each one to find out which, it's hard to determine which one's female and which one's male. They have to test them all. And they had a little dish on TV the other day, so it was a little bit of hope.
So that's really the measure of mosquito control. And that will probably be the most effective public health measure that we can do, as was with West Nile, by appropriately spraying. There is talk, it's premature at this point in terms of genetically engineering ways for the mosquito to be prevented from transmitting either viruses or just from repopulating. So I think that's an extremely important agenda for both the government, why the United States is talking about spending certain high amounts of money to prevent Zika. So that's not going to be used for an individual. That's going to be for public health measures to try to control the mosquito population. And I think that is historically the most effective way to prevent mosquito-borne diseases. We've eradicated malaria in many places by removing the vector of transmission, not because we can treat malaria so well. So that is the wave of the future. It's not today. We don't have the ability to do the genetic engineering right now. We do have the ability to try and control the mosquito population.
Since you said only 1 in 5 who are infected with Zika actually know that they're sick or that symptoms, could a pregnant woman have the Zika virus and not know it, be asymptomatic, but still pass it to their unborn?
Absolutely. So it's critically important for every OBGYN, when they take care of a patient, take travel history. It's not just Zika. Travel history is a very important part of the history that a physician should be taking when they speak with a patient. As an infectious disease physician, that's always very high up on my list of questions to ask the patient. Any patient who's been in the Zika area should be tested if they're pregnant. So any woman who was in the Zika area and is now pregnant should be tested. If the tests are negative, so it's controversial how many times you should do sonograms. I think that the likelihood of doing sonograms in that situation would probably be way higher, and they're considered to be a relatively benign test. They don't really have any toxicity. So I think most people, for comfort and for reassurance, would end up doing sonograms, even though I could argue medically it may not be absolutely necessary. It's very important to reassure patients. So to me that makes it necessary, even though scientifically it may not be necessary. But within reason, you don't do a sonogram every day. Once you show that the baby's developing normally, tests are negative, so then I think the appropriate care would be routine OBGYN care. I don't know if you want to comment.
Well, we would do a sonogram every day if they let us. Every algorithm here ends with, about what to do after testing. Test the patient. If the patient comes out negative, do an ultrasound. Test the patient. If the patient comes out positive, do an ultrasound. And there is no consensus on what the normal interval would be. I can tell you that we do ultrasounds at the drop of a hat in pregnancy. And what the real question is when to start checking in a patient who's gone to a Zika-affected area. If someone has gone in there and they've traveled to a Zika-affected area and they test negative, they're recommending the first ultrasound of serial ultrasounds being between 18 and 20 weeks, which is normally when we do a little early for our level 2 ultrasound. But we would then continue to do them probably on, between 2 and 4 week intervals, probably a 3 to 4 week interval, until anything, particularly intracranial microcalcifications, showed up. Maternal fetal medicine docs are going to get a ton of referrals for this because the slightest thing that the office ultrasound person sees in the brain is going to be referred to MFM, and we're just going to end up doing 10 sonograms on people because we just don't know the answer.
And just to reassure you, it probably is all just to take care of the worry well. if the tests are negative and the original sonograms are normal, then you probably don't have anything to worry about.
I know natural spray. Is there a natural spray that individual homeowners could work on?
So there are a number of non-prescription mosquito repellents that are available on the market. They should be used appropriately, reading carefully. When you spray these things on very young children, that can be a problem. At least they have to be careful about spraying in the eyes. Wearing long sleeve shirts and long pants in areas where mosquitoes are prevalent is an important additional feature to protect yourself. And not going into areas where there are a lot of mosquitoes. Mosquitoes in New York tend to be out around dusk, and mosquitoes tend to be around where there are pockets of water. So in your own houses, in your own areas where you live, if there are bodies of water, that's not where you want to be. If they're potentially removable, the classical example is you have an old tire there that's filled with water, and there's buzzing around it, so get rid of it. Remove any of the potential routes of transmission of mosquitoes. That's the best way.
The ACOG recommends that women use a bug spray with DEET, okay? And you can apply it just the way it says on the thing. It's safe in pregnancy, which is the next question. And it says to treat your clothing with bug spray that has pyrethrin. And those, apparently every bug spray has DEET and pyrethrin. And you're allowed to use them. But, as Dr. Glatt says, avoid dusk, dawn, well, the Zika, if you were in Aruba, it's the mosquito that carries Zika is a daytime biter, a dusk and dawn biter. So, okay, that was
Just saying, you mentioned biological cells.
So there are a number, I didn't want to make it too technical election. Elizabeth's our head of microbiology over here, so she and I will have a discussion about the schedules. But yeah, there are other softer findings that you can see on various specimens that may indicate that the Zika virus is involved in the cell.
I also have a daughter-in-law in this position, and I want them to watch whatever you said, wherever this is replayed. And is that on Facebook and YouTube?
So
And when will it be there?
So South Nassau has multiple levels of social communication that are well beyond my expertise. So we turn it over to James to tell you that you can get it on Twitter, on Facebook, and on YouTube site as well.
When?
It's
It's
up there.
there already, I guess somebody's saying that.
Live streaming up there right now. You can replay it.
It's just South Nassau on YouTube.
It's the website of South Nassau.
I'll get you the information after this. I'll come see you.
Well, we would. Anyone else have a question?
James will get you the information.
At the end, I'll announce. Yeah.
Excuse me, sir. I am going to Brazil in August. I'm trying to convince my wife to come. What should I get her?
So you look like a young man. It would depend on what age your wife is and in terms of
Well, she's
pregnancy.
out of the pregnancy age.
So if somebody is not concerned in terms of potential pregnancy, so then this is a risk that you have when you go to Puerto Rico without Zika. There was dengue. There's a risk of chikungunya. There's a risk of other viral illnesses, other
What
parasites.
precautions you think we should have?
The smartest thing to do is, again, to avoid as much as possible being in areas where there are mosquitoes and using repellent, appropriate nets, appropriate measures to minimize mosquito exposure. There are going to be a mass of people from all over the world going to Brazil in August. The basketball team has invited me to come as the starting forward, but I don't think I'm going to come. We're doing here in South Nassau. But there'll be lots of athletes, young athletes, potentially pregnancy age, male and female athletes, and this will be a big concern in terms of what they're going to do. But I think the overriding government response will be to try to minimize as much as possible the mosquito vector. This lady over there had a question.
What symptoms the same for young children, toddlers,
The question was, are the symptoms?
Yeah.
So that's what I spoke about earlier in the talk. It's theoretically possible. It has not happened yet in the United States. And theoretically, somebody came back from Brazil, had the virus in their blood. As they get off the plane, they're bitten by a New York mosquito. That New York mosquito goes and bites 20 other people. Theoretically, that's possible. Has not happened yet. Hasn't happened in all years with malaria. Has not really happened regularly with any other. So there's no real reason to think it should be addressed.
Schedules this morning. If there are members of the news media here and you have any other additional questions, I believe they have some available time right after this. Again, thank you all for coming, and the video will be posted on South Nassau's YouTube site, and we did stream it live on Periscope on Facebook as well. Thank you very much.